So one of the reasons that we are able to make some predictions about KAT6A, although we need a lot more information from a lot more patients, is that we know about other diseases that work in the same complex and what they look like and what their clinical features are. So you can see right below KAT6A, there are a couple of, there are 3 different proteins actually, and all 3 of those proteins are known to cause these epigenetic diseases. That they all cause certain facial features, developmental disabilities, and things that are different and unique, but also similar to KAT6A in many ways. When Dr. Bjornson talks, you'll hear a little bit more about that, but this is some of the reasons why we think that we can possibly at some point use similar therapies to address all of these disorders, is because they work together in complex, and many of the features that we're targeting are not exactly the same, but are certainly similar. So, we've talked about what KAT6A is and what it does in the body, and you all know that the reason that you're here is that somebody has told you that your child has a problem with KAT6A. So how did this problem happen? What does that mean? So KAT6A is a genetic disorder, which means that in the gene that encodes the protein KAT6A, something happened in your child that gene wasn't correct. The code for that gene was changed and not correct. So how does that happen? Well, there are 2 different ways. So in theory, KAT6A problems are what we call autosomal dominant, which means that if one parent has this disease, has KAT6A syndrome, then there's a 50% chance that any child they have will also have this syndrome. However, we do not, at this time, know of any cases where this has been actually how this has been passed down. Most of the time, what happens is inside, when the baby is developing inside mom, something happens inside the baby only that makes a change in this KAT6A, and that's what we call de novo. De novo meaning new. It happens newly in the baby. So all of the children with KAT6A that we know of currently have this possibility to pass it down to their offspring, but as far as we know, it did not come from any parents. Yes, go ahead.
I think we just saw right on the Facebook site that there's a family in Japan, but three of the 4 children in the family have the KAT6A mutation apparently, so.
Interesting.
Yeah, that was pretty recent.
So that something happens there, and what has happened there is one of the parents carries that mutation in their germ cells. So either the sperm of the dad or the eggs of the mom. So we always tell families that on average, if you have had one child with KAT6A, you have about a 1 to 2% risk. And what that means is that 1 to 2% of people have the mutation in their germ cells, but the rest of the people have no chance of passing it along. So most of everyone, 99%, 98% of people don't have that, but 1 to 2%. And that's, we often see one in one family.
Oh no.
In your germ cell, either sperm or egg.
Oh. But not everywhere in that person's body, because otherwise they would have the syndrome. Okay?
Parents have been tested and came back negative.
So even if the parents are tested, even if the parents are tested, they can still carry mutation in the cells that they don't have access to. Do you understand? So basically the risk is always that 1 to 2%, but that means that 90% of parents, if they don't carry it, are not going to have another child with KAT6. It's a very minuscule problem, but what we see is there are occasional families that have multiple kids. But it's
possible to test all the cells in the body and make sure every cell is free of inflammation.
To follow a question on that, so if you have one child that has KAT6A and you have another child that is normal, is there a possibility that the normal child carries?
No.
No.
This is a schematic of the KAT6A gene. So it's located on part of chromosome 8. There have been some cases where there's a part of chromosome 8 that gets deleted. So the whole KAT6A gene is missing. And most of the other cases that we know of occurs because of a change in the code of the actual KAT6A gene. So it can occur if a whole section of this chromosome is deleted, but it more commonly occurs because you just change one letter in the DNA that then causes that protein to be dysfunctional. So we've talked about what KAT6A does and how a problem in this gene could happen. So what does it look like? So, as you all know, thus far, there are only a few reported cases, which means cases that get published in the literature. You all are here, and most of you have not been published in the literature, so we know there are many, many more cases than what are published, but, the way that the whole community learns about things is cases being published in the literature, and so far, there are only a few. What we do know is that we know both from the cases published in the literature and cases that we have seen in clinic that there are similarities of KAT6A to other histone modifier epigenetic disorders. So those other disorders from that picture I showed back there, they have similarities to KAT6A. So we think we might be able to make some predictions about KAT6A from those, as well as from the actual KAT6A cases that we've seen. So this syndrome was first reported in 2015, so that's why we say it's really very, very new. Everyone who has been reported thus far are children. It is very possible and likely that there are adults out there with this syndrome, but we just have not diagnosed them. Yes? Yes, so we are sure that there are adults, probably even older than that too, with this syndrome. But adults don't go and get genetic testing as frequently as children do. So it's very, very often in these genetic disorders that children get reported first, and then adults get found very quickly. And again, just like we said before, obviously there's a family, and that's why these Facebook groups and you guys knowing each other is so great, because that's the way to get more access to more patients. Because again, thus far, everybody reported has been de novo mutations, so new in the child, but clearly there are cases of germ cell mutations and other things being passed down to multiple children in the same family. There are some features of KAT6A that in the patients who have been reported are nearly universal. So we're pretty confident in saying, yes, these are the features, the cardinal core features of this disorder that we know of so far. Then there are some features that seem to be related. So present in only a few of the patients that have been reported with KAT6A, but certainly present more than you would see in all the general population without the KAT6A mutation. And so those we kind of say, we need more information and more patients to say how closely is this related. So talking first about the features that are considered to be more universal or at least very common. So the first one is hypotonia. So hypotonia means low muscle tone. So this is sort of what people are talking about. You think of it as like a floppy baby. This seems to be, in KAT6A, it seems to be most present in infancy. So the low muscle tone is most obvious in these kids when they are newborn babies. Although a lot of times we know that it persists much longer than that. We think that most of the low tone is obvious, what we call axially, which means in the trunk, the neck, the hips, the center of the body, more than in the extremities, the arms and the legs. And in fact, the arms and the legs can at times, in some reports, be very tight as opposed to very loose. But almost universally, that center of the body, that core, is very loose. The next universal feature that we are familiar with is feeding problems. So these feeding problems are probably very related to that hypotonia that we just discussed, okay? Because we know that kids get very poor oral motor coordination, which means their ability to suck, chew, swallow in a coordinated manner that allows them to eat is very, very poor. Many children, because of this, end up needing tube feedings. Whether that's a permanent tube like a G tube or a temporary tube like an NG tube. Many kids need feeding by tube methods at some point in their lives. And then reflux is very common as well. All of these things can be related to that low muscle tone, but it seems that this is prevalent enough to be an independent issue that is a feature of KAT6A. Congenital heart disease is also something that is seen very commonly, again, nearly universally in this disease. It is not necessarily or even usually some of the more severe congenital heart diseases. Usually it has to do with defects of the septum, which is the wall that separates the chambers of the heart. So you can have an atrial septal defect, a ventricular septal defect. Both of these, and even these two together, have all been reported with KAT6A. Other congenital heart disease is a patent ductus arteriosus, which just means that the blood vessel that's present for babies in utero doesn't close up the way it should in patients with KAT6A, or patent foramen ovale. There have been other congenital heart diseases reported, but not frequently. These are the most common ones that have been reported. Eye problems. So again, a lot of this also gets back to that hypotonia. So, you'll see that these things are very related to just general problems in the brain. So very commonly, these kids have one or both eyes with strabismus, which is otherwise known as a lazy eye. They can have ptosis, which ptosis means their eyelids droop down onto their eye. And then lots of other vision issues, nearsightedness, cortical visual impairment, other sort of vision issues have been reported. But certainly the strabismus and the ptosis are very common. Skull abnormalities is another one. So craniosynostosis means the skull bones in your head fuse too early. So, with all babies, they're supposed to have these soft spots. And a lot of times, our kids with KAT6A, they don't have those soft spots the way they are supposed to be. Their skull bones got completely fused before they were supposed to, which can create abnormal head shape and have to lead to surgery. Microcephaly is also commonly reported, which is a small head. A lot of the reports talk about distinctive facial features in this disorder. So things that have been talked about are what we call bitemporal narrowing, which means that this area here on the sides of your forehead are more narrow in these kids than in other kids. A very wide and bulbous nose. Then several other features have been reported. Another one that's really common is this triangular or tented mouth. And again, this can come with a host of other things, but these are some of the ones that are very, very commonly seen. And as you can see in pictures, and then looking out amongst yourselves and your children too, certainly all of your children look like you in different ways. They look like their mom and dad, but they also have similarities to each other that are very different than the familial look that they inherited. And then probably the most common, most universal, biggest feature that we've seen is this global developmental delay. So when we say global developmental delay, what we mean is developmental delay in most or all areas of development. So gross motor delay is seen very commonly, meaning they're late to sit, crawl, walk, all of those things like that. This is probably twofold. It's probably partially related to brain disease and partially related to the hypotonia or the low muscle tone. Then intellectual disability is reported universally in this disease. So most of the cases that have been reported are moderate to severe intellectual disability, although there have been a few kids who have been on the mild end. And then as part of the intellectual disability is a prominent language and speech impairment. So a large number of KAT6A kids are completely nonverbal, or if they do have words, their words are very often even behind what their intellectual disability would say their capacity is. So their language is their toughest skill, more so than a lot of their other problem-solving skills. So then we get into some of the less common or possibly associated features that are reported. So one is small birth size. So a lot of these kids are reported to be small at birth compared to what their gestational age would predict. So full-term babies being a lot smaller and looking like preemie babies. Again, this is not universal, but it's been reported in more babies than you would expect with KAT6A. Postnatal or after birth slow growth has also been reported, but this is a lot more inconsistent. Perinatal complications around the time of birth are very common. These may also be related to that hypotonia issue. But a lot of kids with KAT6A are reported to have to be born by emergent C-section. A lot of them were in breech positions. Many needed NICU admissions for some help with breathing or feeding or things like that. Again, much more commonly than you'd expect. Seizures. Seizures do not seem to be common in this disorder, but again, more prevalent than you see in the general population. But when we have seen seizures with KAT6A, they've been many, many different types. So anything from infantile spasms, which is a very severe early kind of seizure, to more common types of seizures later on in childhood. So specific behavioral features. So the answer is we have no idea. So there have been a case or two reported with who are reported to have autism. You know, there may be an anxiety component to this. There may be other specific phenotypes, but the answer is there just hasn't been anything on it, so we don't know. We know that there's going to be the global developmental delay, and we suspect that there's going to be speech and language more so than other streams of development. But as far as behavioral phenotypes or more specific cognitive phenotypes than that, we just don't have the information yet. Sleep disturbances. So there have been a lot of sleep apnea reports. Could this be hypotonia? Yes, absolutely. And then just sleep cycle disturbances. Really, really hard time getting these kids to follow a normal sleeping pattern and sleeping through the night. How common is this going to be in this disorder? We don't know yet, but it has certainly been reported. Immune system irregularities are something we know from other epigenetic conditions that are, theoretically related to KAT6A. Some of the cases have reported frequent ear infections and upper respiratory infections in these kids. One case is reported with frank neutropenia, which is a dangerous kind of immune system irregularity, but the jury is still out on this as well as to how common this is and whether or not it's really a problematic feature of this disease. Dental abnormalities, again, common in other epigenetic conditions, have been reported. A whole host of things needs to be further delineated. Hand abnormalities. These are minor things, but lots of things reported with these kids. Curved fingers, that's what clinodactyly is. Brachydactyly is short fingers. A single palmar crease on the hand. Again, mild things, but things that we're not sure how related and how much we see in KAT6A versus other things. And then brain MRI abnormalities. Many of these kids have had a brain MRI. Many are normal, many are abnormal. All the ones that are abnormal seem to be abnormal in many different ways, and not totally clear how the abnormality correlates to the disease, especially when we're talking about that difficult birth thing with the emergency C-section and stuff. It's unclear to say how much of these MRI abnormalities have to do with that, with a difficult birth and things that happen related to that versus how much they have to do with the underlying disorder. So more data needs to be collected on that as well. And so the bottom line is we have to learn from you all. So you all are the best sources of information to tell us what is common in KAT6A and what's not, and what's a part of the core disease and what are just other things that may or may not happen. We need to draw, like I said, from other similar epigenetic syndromes and find out how much overlap and how much difference there is between KAT6A and these. We need to look at the patients already published. And again, we learn most from you all. So thank you for your time. And I can take a few questions and then we'll move on, and I can of course take questions later too. Yes?
I think another thing we were curious to find out is if there are issues around blood sugar and sort of need to persistently snack and craving the carbohydrates, because it sounds like there might be something that other families are experiencing.
So that's a wonderful question. There isn't anything out there currently about that. But certainly that's something that we see again in other these epigenetic conditions that are related to KAT6A, that they can drop their blood sugar more easily. Sometimes that can have to do with the feeding problems. There may be something more intrinsic and metabolic going on. And my guess is that Dr. Kelley is going to probably touch on that a little bit also. Yes.
So in regards to birth defects,
Okay.
there's a pretty wide range of birth defects. Some kids have some kids have none, and then there's kids like Savannah who have a lot. How does that happen? What causes differences in birth defects?
Birth defects as far as different organ systems and body parts that are abnormal at birth.
Correct.
So that can be caused by a number of things. So again, there have been a number of those reported with KAT6A, but just like you said, some here, some there, none here. And so it's unclear which parts are going to be a feature of this syndrome. But there are also parts that we know about this syndrome that can be related. So that whole hypotonia, I know I keep coming back to that. But if you're inside in utero, if you're in mama's belly and you are hypotonic, you don't move around as much. And when you don't move around as much in there, it can cause it can actually cause some birth defects, okay? Because you're kind of stuck in one position, and that can cause deformities in the extremities and things like that. So the answer is we're really not clear what's what. But certainly, like I said, the congenital heart disease, the skull abnormalities, those kind of things are definitely going to prove to be a cardinal feature of this disorder. And everything else we got to figure out, is it random in this one kid, or is it something that we have to sort of look out for, even though it's not the most common feature of this disorder?
Thank you.
Of course, yes.
So, I'm Cora's mom. She's the youngest diagnosed as we know today. She'll be 10 months next week, and I'm interested in the hypotonia, because what I've been told is that she has hypertonia, but I'm not sure how accurate that is, because she has physical therapy and all that stuff. So she has her trunk support. She's always had really tense muscles.
Yes.
If I lay her down, she'll like hold her head up from a really young age. So she can sit up really well. That's the only like motor skill that she has. Like she doesn't roll over, she doesn't crawl, any of that stuff. And her physical therapist says that like she's compensating. Like she says that she's not using the right muscles to sit up. So I didn't know if like I've been given a wrong information in that, and it's actually hypertonia and she's just compensating. You know what I'm saying?
Yes.
So that's kind of my one question. And then my other thing was I didn't know about like the traumatic birth being like a thing that KAT6A kids had, because I went into like my water broke naturally with her, but then I had a 20-hour labor and she was stuck under my pelvis, and it was like a traumatic situation eventually. Like I had to be induced eventually, and it took a really long time. So I didn't know if like, I thought it was just like, oh, different baby, different, things, but it might be related to her disorder. Yeah.
Yes. So addressing the second question first, yes, it may be related, okay? And again, not to keep harping on the same thing, but that low muscle tone, right? So if you are, if you're not very tight, if you have low muscle tone, it makes it a lot harder to get through the birth canal and to do everything that the baby needs to do to get through the birthing process. And so is that the only reason that we're seeing these increasing difficult births? We don't know yet. But that could certainly be related. But either way, it does seem that the KAT6A kids have more of the difficult births than the typically developing populations. As far as the hypotonia versus hypertonia, it's very, very common that kids with lots of different brain diseases, and this one as well, can be low muscle tone in their trunk, in their support muscles, but very, very high muscle tone in their extremities, so their arms, their legs, their neck, things like that. And I haven't examined her daughter, but that is very, very possible. So my guess is you were not given a wrong diagnosis, that in fact there are a mix of things going on, which is very, very common, not an unusual situation. Yes.
Are you aware of any upcoming or ongoing research studies on KAT6A other than the ones that were published?
Not currently, but we're gonna talk a little bit more about possibilities for that shortly.
Okay.
One update on that. So I think many of you completed the survey that Dr. Arbolita made available to the community. So she just updated that she'll submit, I think, next week for publication.
Okay.
Results of that. So that'll be a new clinical paper, right? It'll be 76 total patients,
Great.
52 of which will be new to the literature. So hopefully that gets reviewed through, published within a month, 2 months, whatever the normal timeline is. 6 months.
6 months, yeah.
Yeah, so soon that'll come out. And again, I don't think that'll be so much research focused as just adding patients to literature to better characterize the disorder.
Which is very important at this stage of the new disease, so that'll be great, yeah.
Jordan, is she coming yet?
No.
How do we know? I started that survey,
Yeah.
but I don't think I finished it. I'm curious
your
If I got
results made
kicked
a
back
difference.
out.
Yeah, I would agree, because I did it, but I don't actually know if they made it, if there was no confirmation that I finished it in the
Right.
right way, so that's why
Yeah,
Could you give us a list of who's completed it? Do we have access to that?
I don't know, we can certainly ask her for it, if she can, we can provide that in advance. I mean, she did indicate that, you know, at some point she had to go and publish, right? She had to draw the line somewhere for those that had completed it at that point. So I think partially completed ones are probably not included, would be my assumption, but if you felt you completed it and submitted it, I would assume you're good and you're in there. But yeah, we can try to get a list in advance, maybe more.
Okay, I'm sorry if you discussed this, I had to step out, but Hudson's primary diagnosis for a very long time was mitochondria disease. He has a mito doctor down in Houston and we did muscle biopsy. And then, we reran some blood samples and did X-rays with me, and that's when the KAT6 popped up about a year ago. So he is actually on a clinical trial drug for KAT6A. What are the benefits that you see to treating mito?
I'm gonna defer that to Dr. Kelley, actually, because that's probably what he's gonna talk about. Yes.
Is there any information on how long these kids do have some of the cardiac surgeries? Do they react differently to anesthesia?
That's a good question. We don't know about the anesthesia. Certainly that's something that we're concerned about in any kid with low muscle tone and brain disease. So we don't know yet. Luckily, a lot of the KAT6A reported congenital heart disease are mild and sometimes close on their own without requiring surgery. But I think we do need to collect data on that because the anesthesia concerns are a real risk. Yeah.
I have a detailed anesthesia protocol for and I can make that available. It's good to get that to the anesthesiologist and the surgeon.
When Hudson had open heart surgery down at did something very different.
This actually is a standard protocol used here at somewhere in the process of being published by the anesthesia group, but I think it's available to email.
So sorry, I don't want to monopolize it. So Cora has a PDA that they found, early on, and they were like, oh, we'll check it later. It hadn't closed. They were like, oh, we'll check it later. It hadn't closed. Now they're like, we'll see her again when she's 3. So there have been people who have had that it's closed up on its own. Because if it's still there when she's 3, they're going to. You what? Yeah. Okay.
All right. Can I ask one just quick question? The hypotonia, is that sort of a direct, the constipation is sort of a direct result of hypotonia?
So yes, yes and no. So definitely hypotonic kids have constipation, right? You also have a large amount of nerves in your gut, just like you do in other parts of your body. And so it's also common that kids with brain diseases in general have constipation. So, I think it is very, very common. It's something that we hear frequently. There are some disorders where we hear it more than others, even others with hypotonia and brain disease. So I think it remains to be seen, where KAT6A falls on that spectrum. If there are really specific constipation GI problems that go above and beyond, hypotonic kids with intellectual disability, or whether it's just going to be that. But the answer is yes, hypotonia and intellectual disability both have a correlation with constipation.
Is it possible that antibiotics can affect kids differently? The reason I ask brain constipation, Sarah's dealt with constipation for a long time, and then last year, about this time, she got an ear infection after her initial tubes fell out, which didn't clear. They gave her 3 rounds of antibiotics, increasing in their strength.
Yes.
Through the end of April, and then the beginning of May, her bowels went completely the opposite way. And starting in July, they had us doing elimination diets. I mean, she was dairy-free, soy-free, with everything free that you can think of. She was free of. And we're reintroducing things, and it seems like now she has an issue with eggs. Gluten seems fine. We haven't reintroduced dairy yet. Soy protein seems to be an issue, but not less even. But these things weren't problems. I mean, she's 5 and a half. These things weren't issues at all until May. Is it possible that the runs of antibiotics would have
Certainly we know that lots
permanently, or
well, certainly we know that lots of antibiotics can change the gut flora, which can then bring lots of different GI problems. And how permanent that proves to be sort of depends.
Yeah, because we're trying to figure out if it's an allergy, or if it's like
If it's something
how to deal with it.
Absolutely.
We did.
So again, I'm happy to meet all of you, as I'm sure I've emailed many of you. And what I'm focusing on treatment and trying to bring up to date on what we understand about mitochondria and KAT6A. I have spent many years studying mitochondria, of course, I was here, and there's clearly something going on in mitochondria, and I'll discuss what mitochondria are for those of you who are not familiar with it, and try to link what we've seen, what parents have seen clinically with various types of mitochondrial treatment and what we understand about the biochemistry. And in doing that, I'm going to I'm not sure how to advance the slides.
Down the bottom, down to the bottom.
For some reason it wasn't working. So this is more or less what I'll be going through. And I'm just going to, the main goal is to try to make sense of mitochondria, or that you understand what we understand about it and how we can go forward from here in taking what information we have. Now, I have now collected some that have all about 20 patients. So we have a database, so to speak, to start off with. And I'll try to, it's a little complicated, I don't want to bore you all with biochemistry, but what I'm trying to do is give you some concept of how we approach a mitochondrial disease. So I'm at least assuming, and I would evidence that there's some type of mitochondrial dysfunction in KAT6A. And then the question is, what can we do to make the mitochondria better? And in part because mitochondria are so closely tied to nutrition, that gives us avenues to work with the mitochondria and try to change their function. And suffice to say that KAT6A, one of the major effects of KAT6A or of any of the acetylation systems is to read what the mitochondria are doing. And there's a direct interaction between mitochondria and KAT6A, which is an acetylation system. That shows up. So the acetylation, KAT6A is an acetylation. Okay, I'll try to put it right in my mouth. Anyway, KAT6A is an acetylation, and acetate is the same thing as vinegar, acetic acid. It's a primary fuel for the body. How how food is converted into energy. Food is converted into body, protein and other parts of the body, and it's also converted into energy. So I'm going to go through how we try to interpret the signs of mitochondrial in a disorder like KAT6A and therefore draw conclusions about how to treat it. And I'll be showing you examples of how this has been approached in other syndromes, some of which are very much like KAT6A and how they work. I think it was Dr. Esther that first contacted me about KAT6A, and I can't remember how she got in touch with me, but it was very interesting because it brought me full circle. It's been, I'm really embarrassed to say that it's been 35 years since I published this first paper I published as a graduate student, and it described that histones form complexes, and those complexes are what Harris showed. These are what KAT6A is functioning, is working with. So it's really very satisfying for me to finally, after all these years, come back home, so to speak. I worked on the histones and chromatin for my PhD, and then I got sidetracked into mitochondria. So now we're sort of bringing it all back together. So mitochondria are the energy sources of the cell. Here's just one picture, probably most of you have seen it. Each cell has many mitochondria. The mitochondria are complex organelles that are enfolded like this, and on these enfoldings is where all the ATP is made. So there are so-called electron transport chain proteins that are in this area of the cell, and this is where food is converted into energy. This just shows you what the mitochondria are like. This is staining of mitochondria to show that they're not always these sort of football-shaped organelles, but they can be elongated like this, and they travel along the within the cell, and they can actually move to where energy is needed in the cell. This is especially important in brain function in terms of fitting mitochondria into the part of the brain and part of the cell where action takes place at the synapse. So understanding mitochondria both as a functioning organelle and as a dispensing system, so to speak, of energy is important. We haven't addressed this aspect of increasing mitochondrial delivery to certain parts of the cell, like the brain and the synapse, but there are ways of doing that. This is I'll tell you, this diagram gives most medical students nightmares, because every medical student has to learn as a cycle. And I am showing you this because there's no easy way of doing it, but we really have to understand, or what I have to do in working in trying to understand what's going on in mitochondria is this aspect here, the fact that I should say this is the citric acid cycle, and it's a true cycle that works in the cells. Food comes in here, glucose or fat or amino acids, they're converted into acetyl-CoA, and this is very important in KAT6A. They citrate, and then citrate is broken down in several steps to come back to this compound and then make citrate again. And in this process of breaking down and oxidizing citrate, that energy is made. What's very important is the fact that amino acids also feed in at different steps. And one of the fundamental principles that we've learned in the recent years about mitochondrial treatment is that the general thinking in mitochondria is that if you have a mitochondrial problem, the mitochondria don't make enough ATP. That's actually not quite right. It turns out that the mitochondria make as much ATP as the cell needs until the cell dies. And what is in fact going on is that the mitochondria break down the cell. They cause the cell to release amino acids, and the cell then spends a good deal of time starving, in effect, because the amino acids that normally would go to make protein are being broken down. And eventually the cell runs out of one of these, and the cell dies. So it's not ATP, it is ATP synthesis, yes, but to understand mitochondrial disease is to understand what the mitochondria are doing to the cell to make energy. And if we can, if the mitochondria are impaired, we can work with the mitochondria, we can treat the mitochondria in a way that we can make more, that they won't damage the cell, then things will be better. So the citric acid cycle, as I said, is located on these cristae. And this is a diagram some of you have seen. I did a webinar a while ago, and this is a diagram I made showing what might be going on in the mitochondria. I showed you acetyl-CoA before, and acetyl-CoA is converted into acetyl-carnitine, and then acetyl-carnitine is converted back into acetyl-CoA and acetate, and it's acetate that gets into the nucleus, and that's converted into acetyl-CoA. So the goal is to increase acetate in the cell, in the nucleus. And KAT6A, as you know, patients who have a deficiency, they have one normal function. And therefore, if one can increase the amount of acetyl-CoA that the KAT6A will use, then it can partially compensate for the deficiency of the KAT6A protein. And that's the primary goal of treatment. That's only one aspect. That's treating the primary defect, but it's not likely to be a complete cure of the biochemical abnormalities, and that's why we have to look at the rest of biochemistry, understand how to support the cell as much as possible. And I should say, what I believe carnitine is doing is enhancing the transfer of acetyl-CoA out of the mitochondria where it's made and into the cytoplasm. And that's where it's converted into acetate and taken up into the nucleus. So this is where carnitine may be playing the role in the improvements that people have seen in their children who are taking carnitine. And what we know for sure right now is that carnitine is beneficial. Even though we don't have formal trials, I think the anecdotal experience has been quite striking. My experience has been mitochondrial specialist. And it also, the kind of changes that I've heard about are exactly what we see in treating certain groups of mitochondrial diseases where there's a primary abnormality in the electron transport chain. So the question is, what is an amino acid? An amino acid is a compound that is in protein. Protein is a string of amino acids, and when someone eats, the protein is broken down into the individual 20 amino acids that are in protein, taken up into the bloodstream, distributed to the body as needed. A lot of it goes into muscle, a lot of it goes into liver as a store, but some of it goes directly to the brain and other places. And what I'm trying to show here is that there, some of you are aware that I asked that amino acid may change at 4 to 5 hours of fasting. That's a special point of equilibrium where the blood levels tell us much more about what's going on under the blood right after the meal or fasting. And what I'm trying to show here is that these values are, I'm going to skip that and go on to the next one. So again, all these amino acids will feed into the mitochondria. When the surge of protein from a meal is gone, then it's the mitochondria that determine the level of amino acids in the blood. So if we obtain the blood at 4 to 5 hours fasting, that we can interpret those levels as a sign of what's going on in the mitochondria. And what I was showing back here is that in complex 1 deficiency, this is a child with autism. In complex 1 deficiency, there is an increase in glycine and alanine, and it's about 2-fold increased here. And this might not be apparent right after meal or after overnight fasting, but we can look at this profile. This profile by itself is essentially diagnostic of complex 1 deficiency or the equivalent thereof. So one can look at these ratios and draw very specific conclusions about mitochondrial function. And this is just to show you that I've already said it. I've done a lot of studies on autism, and it turns out that about half of autism is caused by mitochondrial abnormality. And there are 2 types of autism: progressive, where children are normal and lose their skills, and non-regressive, where children are typically not normal from birth. And as I said, I'm looking at this is a method where this is what I've done for all of your blood samples, is if we obtain the blood and do a calculation on it, we can put a normal blood level of 1.0. So what this shows is in the children with autism, with progressive autism, that glycine and alanine are increased relative to the controls. This is the control range here, normal range. And these are distinctly increased. And this allows one to, the child has symptoms of autism, to just do an amino acid study rather than a muscle biopsy and determine if there's an abnormality in mitochondrial function. And this also, the combined increase in glycine and alanine also tells you how to treat the child. So this is the kind of information that we're looking for with KAT6A. I should also say, I'll come back to this later, that in some of the patients with autism, the tyrosine is low, and that is relevant. Tyrosine is a precursor of neurotransmitters, dopamine, norepinephrine, epinephrine. And according to deficiency in tyrosine, then the neurotransmitter levels can be low. And I'll show you the consequence of that later. This is the standard treatment for complex 1 deficiency that we do for mitochondrial autism. This is the kind of cocktail that Chloe started on, and it is designed to do 2 things. One is to augment the activity of complex 1, and the other one is to treat reactive oxygen species or free radicals. These form in conditions that are in certain types of mitochondrial problems, and they damage the mitochondria. And if the mitochondria are damaged by free radicals, then they don't work as well, and they make more free radicals. And that's why mitochondrial conditions often get worse with age. And if we can protect the mitochondria, first we can stimulate the mitochondria to make more energy, and we can protect the mitochondria with these. With this specific combination of antioxidants. And this works very well in most classical mitochondrial problems. And right now, all I'm convinced of is that carnitine in particular is beneficial. But we now have evidence that maybe the older children with develop mitochondrial function, and therefore the question whether treating with carnitine and pancreatic acid would prevent this damage to the mitochondria over time. It's very specific. We can do tests that tell us very directly whether the mitochondria are damaged and if they need antioxidants. And in general, I have not seen that in the tests that have been done, except in a few older patients. So we have suspicion that it is getting worse with time. And that because there's such a clear benefit from harnessing the pantothenic acid, which works together, then there's a very real possibility that that alone will be adequate. There's no harm in giving the antioxidants, just a harm to the pocketbook. But it's, you don't have to give all those extra medicines. And that's one of the goals that I have in the next few years, is to set up some formal studies with children to be able to study this aspect and to determine whether through formal treatment protocols where we monitor for frequent various exercises to really answer the question of whether or not quarantine by itself is adequate. I'm not saying it shouldn't be adequate, and I had discussed things with Kelley's father on the phone a while ago, and it's quite clear that the immediate effect, the relatively rapid effect that one sees with the cocktail. So Chloe was given the cocktail, and it was, I think, more or less based on my recipe, and some benefits were seen within a few weeks. And the antioxidants take a minimum of 3 months to have an effect. So we start the cocktail all at once, and the child gets better. We know it's the quarantine at least that is working. And what we don't know is whether the antioxidants have an added benefit. And that's what we'll try to sort out. It's going to take more formal protocol studies, but that's the primary goal that I have as someone who works with mitochondria. So here is, so I'm talking about amino acids. I'm going to give you now several instances where finding an where the amino acid is critical to the treatment of a mitochondrial problem. And this is about methionine. And methionine is important because there has been some methionine deficiency in patients with KAT6A. And so I say that in certain types of mitochondrial problems, methionine is the critical deficiency. It's as the mitochondria become weaker and they draw more on the amino acid, some amino acid has to run out first. And it's usually methionine that runs out first. And methionine, there's not a lot of that in the diet. So, and there's not a lot in the body, and it's a very, very important compound in many things other than the protein. So this is a child with Leeds syndrome, which is a very severe type of mitochondrial problem, and it's fortunately treatable now. And I've followed this patient for about 20 years. And when he was in his late teens, he started. All I can say is that he just wasn't as well as he should be. He did well for many years, and he started having more problems. He kept racking our brain. He's on a treatment that I know is working. What could be going on? And just in doing his blood counts, what I found is that his red cells were getting larger. And a larger red cell is a sign of B12 deficiency or folate deficiency. So I measured his folate and B12, and they were high, not low. And yet he clearly had a rising MCV, and it really jumped up here, as you can see. This is the upper limit of normal, and it jumped above normal. And when I couldn't find that he had B12 or folate deficiency, I measured another compound, which many of you here have measured, called homocysteine. And if normally when there's a blood problem where the NCV, the size of the red cell, is going up, the homocysteine was high, but in this child, the homocysteine was low. The main source of homocysteine is methionine. So I put him on a relatively small amount of methionine. And I should say here, I forgot to mention, the methionine level in blood was not low. So here's 7 to 43 is the normal range, and it was 13, 22, and 20. But when I calculated it as relative to all the other amino acids in the blood, it was low. Not very low, but it was low. So this would never be picked up by a regular laboratory. One has to do the ratio study. And so I put him on a small amount of methionine, and his MCZ dropped like a stone. It dropped as fast as it possibly could, given the fact that red cells live for 4 months. So this is proof, and he got better clinically. That's the most important part. So that's proof that the methionine deficiency was what was making him sick, not the fact that he had a mitochondria. The mitochondria caused the deficiency of the methionine, that led to this is a young man who I have been treating for the past few years, and he has mitochondrial autism. So he was normal to a year of age, had an illness, lost skills. He actually had 2 episodes of losing skills, and he's sort of on the borderline between Asperger's and autism, and he has to be not an independent child. And what I saw in his studies is that he had the usual things that we see, a high level of choline, glycine, and alanine in particular. And he also had a low level of tyrosine. Again, the tyrosine level itself was not low. As a ratio, it was 0.7. Anything below 0.8 is low. So it was very subtle, but it was real. And so I decided to do that, to put him on a supplement of tyrosine. And this photograph had been before treatment, and it shows that he's not a very active camper. And his mother says that he's just always, he's okay, he can take care of himself reasonably well, but he just never enjoys anything. And he really had mitochondrial dysfunction, and so we decided to put him on tyrosine. And that's the difference before and after. So this happened December 2016. His mother's, he's just totally changed. He's outgoing, verbal, and his mother said that this Christmas 2016 was the first time he enjoyed Christmas. And he's continued to do extremely well. And so again, the subtle deficiencies of amino acids are very important. And the reason it's hard, the reason it's not been recognized before, and the reason it's hard to detect is that if there is a deficiency of amino acid in the body, the liver tries to pump up the level in the blood to supply more to the rest of the body. So the blood can be low normally, but in the tissues it can be very low. So that's the reason that this is again not been found before. And we found it first in a syndrome called Bart's syndrome, arginine withdrawal. And that cured the heart disease and Bart's syndrome. So now we're finding that there are three primary victims, so to speak, in amino acids and mitochondrial dysfunction. One is arginine, and this I'll skip that. It's just to say that tyrosine is a precursor for neurotransmitters, and in effect what was going on is that he was deficient in the nerve cells in tyrosine. In fact, when I put him on tyrosine and he got so much better, his tyrosine level didn't change. It stayed the same. All that extra tyrosine going into the nerve cells. And it was really a tiny amount compared to it was only about 25 to 30% of the daily tyrosine. So he was deficient. He needed it. Here's another young man I followed for many, many years. And all we knew is that he had a syndrome, and he had some signs of mitochondrial dysfunction. I tried treating him with a mitochondrial cocktail, and it helped a little bit, but it really didn't help a great deal. And he was fairly alert as a young child, not doing very well as a got older. And I found that he also had a deficiency of methionine that was shown here. Again, the same kind with normal levels in the blood. And what we found out when we found that he had is he had an abnormality. What we found out he had is similar to KAT6A. It's a histone modification, but it's methylation. And the methyl comes from methionine, and he has the same kind of abnormality. He has one copy that's normal and one copy that's abnormal. And so I put him on methionine, and again, a very small amount, and that was the change that was in it. That's over the matter of just about 6 months, I think. Clearly, he has trouble still. He's not an independent person, but he started telling his parents what he wanted, and he hadn't done that before. And he was very busy, put on a fair amount of weight. He started eating diet, but just to show again, methionine deficiency was critical for him. And the methionine I'll show comes in here. And the most common site of block in mitochondrial problems is in the first half of the citric acid cycle. So if there's a block here, and we can show this block by measuring these compounds in the blood. And then the methionine and these 4 amino acids here become more important, and the mitochondria uses those to make energy. And the methionine, even though all 4 can provide energy in this way, the methionine gets picked on for reasons we don't understand. And that's the weakest link that becomes both first. So in general, just to give you some idea of our resources for treating mitochondrial problems, and we've only really addressed the issue of carnitine and KAT6A. I have to first understand more about the metabolism of KAT6A to know how to approach it. But these are the kind of things that we do. Again, carnitine and pantothenic, you know about. Complex 1 is, in almost any kind of mitochondrial problem, complex 1 is lower, has lower activity, and it happens to be where carnitine and pantothenic work. It literally turns on a switch that activates some part of complex 1 that's not active. And that's why you see such a rapid effect. Carnitine is more soluble, it builds up in the body very quickly, and pantothenic acid works in concert with carnitine to activate complex 1. So then we use antioxidants, as I already mentioned. Another way that has not been explored in KAT6A, which is very important in some of the mitochondrial diseases I treat, is stimulation of the NRF2 pathway. I think someone here mentioned Epi743. Is that?
Yeah.
Did you mention Epi743?
I'd say we've been on that for probably 4 years now.
And where did you see?
So he was admitted to that under the emergency treatment protocol, and we immediately saw an immune system reaction. He used to be so sick constantly, multiple hospitalizations, and now, I mean, maybe one hospitalization a year. Definitely helped his immune system. And we saw Dr. Inns at Stanford, and the very first thing he said when we came back after having been on it for 6 months was his attention span is so much better to focus on things, where before he was very chaotic.
So these are something that needs to be explored. The question is if you give both farnesene, farnesene pantothenic acid, and epi-743, would that have an additive effect? What epi-743 is, it sort of has an interesting history. They have found that gamma-tocotrienol stimulated what's called the NRF2 pathway, but you can't patent the natural compound. So the company that was making it engineered it so it had the same function, but they like stuck a metal group on triangle, so it's called a drug. But I've been using gamma-tocotrienol for about 20 years in my patients, and it definitely can help. It doesn't help all mitochondrial problems. I just don't know the question right now of whether adding that inhibition is on now just the epi.
He's just on the epi. They made us get off of CoQ10 to get onto the trial. Yes. He could be on carnitine, but
so
he's on that for
all this data is very important. I'm not saying he should be on carnitine, but that's the kind of question. What I usually do clinically is I'll start a patient who has a mitochondrial problem on carnitine and the antioxidants. Sometimes if they're very sick, I'll throw in the gamma-tocotrienol at the same time. And sometimes I'll add it later. This, I should say, is available over the counter or by email.
So I'm just wondering, my daughter has been told by several specialists that her levels are fine enough to not need any of this. However, that was what's told to us by a GI doctor, and it was again told to us by a geneticist. So I'm just wondering, at what point does somebody make a final decision to say whether or not someone is truly benefiting from the mitochondrial treatment?
It has to be evaluated. Most patients, just to give an example, almost all patients in whom I make a diagnosis of mitochondrial autism, all laboratory studies are normal. Because the values are not that increased, one has to use the ratio method to show that there is an abnormality. And then you can go on and confirm the abnormality by other means. But as a screening test, amino acids are very valuable, but in commercial laboratories, if it's within their normal range, which tends to be very broad, they just say it's normal. They don't recognize it. So it has to be evaluated by someone who knows mitochondrial function. Not how it could, but in general they don't. So it's who is looking at the data to make sense of it. And simply saying that everything is in normal range, unfortunately, for diagnosing mitochondrial dysfunction, it just doesn't work. You have to have someone who knows mitochondria to interpret that.
I have a question about the E5. What is it do? Does it make the carnitine more effective? What's the role of E5? I know that it was on the other side, but is it necessary to give that as well?
I can show you what you're at the beginning.
Because I had a really hard time administering that to him.
Yeah, it is a, here it is. So, acetyl-CoA, when we work with, it's very common that when the mitochondria are being overworked, that they use up B vitamins more rapidly. And Barr syndrome, which I mentioned before, B6 is very often deficient. But it's enough to cause trouble, but it's not enough to be recognized as B6 deficiency per se. In fact, B6 deficiency usually leads to an increase in binding. Pancreatic acid is the source of making acetyl-CoA here, or this is CoA is made from pancreatic acid, and therefore, to make sure that there is adequate pancreatic acid, we give our adequate coenzyme A, we give pancreatic acid. It also, studies have been shown that unlike some vitamins, one can increase the level of acetyl-CoA, of CoA, simply by giving B5, giving pancreatic acid. Unfortunately, it's very hard to sort out what's helping, or if we give a cocktail to the patient, it's very hard sometimes to sort out what is doing what. And I'm reasonably convinced that in patients with classical mitochondrial disease, pancreatic acid can help. I don't know for sure for KAT6A, and if you're having trouble giving it, what I would do is give less of it. The daily requirement is 15 milligrams, and most of the patients are getting something like 50, and it can be irritating to the stomach. So if you simply give a multivitamin, which has 15 milligrams of pancreatic acid, that is enough to cover a deficiency, a secondary deficiency. It's not going to give the amount that we give mitochondrial patients, but I can tell you right now that it definitely is needed. So I would not be terribly concerned, as long as you're giving at least one daily requirement extra, that would probably be enough. I just wanted to show you what I'm working with now in terms of so I'm going to show you a summary of amino acid data that we have so far. So this is the summary of the data that we have so far with KAT6A. It's about 20 patients. How many we've got here. And it's not consistent. You don't always see average values, but they're not the same in every child. And this may be because, as I explained, the whole interaction between KAT6A and mitochondria is related to diet. And therefore, the diet a child is on will influence the function of mitochondria, or the interaction of KAT6A with mitochondria. And that's very important. Diet is the main treatment for mitochondrial disease. And this is one of the things that we have to understand. What is the best diet for someone with KAT6A? So to show that the most unusual findings are a high level of citrulline, which is here. And it's about half of the patients. Again, this is standard. This is Z-score. So anything above about 1.25 is normal. So half the patients at least have a high citrulline level. And also a good number have a high asparagine level as well, which is here. And some are quite high. They have high alanine levels. This is more characteristic of typical complex 1 deficiency type with mitochondrial dysfunction. They also have, I can't really explain it, they have a relatively low level, as a group, have a low level of lysine. So there are many, all I can say is that there are many effects of KAT6A deficiency on mitochondrial function as manifested in the amino acids. We know that carnitine is helping. It may be helping not because it's changing any amino acids, but because it's stimulating the production of acetyl-CoA, which then gets into the nucleus, which is where it is needed. These are all the things that we have to tease out. I've been working with this other condition, Bart's syndrome, for more than 20 years. And fortunately, every few years we come up with something new. There are three main problems with Bart's syndrome. One is a muscle problem and a heart problem. One is neutropenia, a low white blood cell count, and the other one is growth hormone, or growth hormone. And gradually, bit by studying the metabolism, studying the fatty acids, the amino acids, we've been able to figure out the cause of all three of those problems. And we've treated one, and we're pretty sure how to treat the other. Just to tell you, it takes a long time to gather a lot of data. And fortunately, now have a sufficient number of children to study that we can gather that kind of data. And it's a complex process for eventually doing that. I can only say each child is probably, as these show, each child is going to be somewhat different. So there's no one treatment that fits all. And that's been the truth with Bart's syndrome and other mitochondria. Even though the diagnosis can be the same genetically, the treatment is going to be affected by other genes that a child has. But we have these tools, these metabolic tools, for looking at the link between nutrition and metabolism. And because KAT6A is a metabolic protein that has metabolic interactions with acetyl, which comes from mitochondria, that is what we need to do. I'll address one question right now and then open up to. There's two problems with the GI tract with KAT6A. One is there's a high incidence of malformations, and this is evident or a structural abnormality because there are now patients who have intussusception, which is not a very common finding, and it's usually associated with dysmotility caused by structural abnormalities in the gut. It could be other causes, but these have to be named. The other thing is that chronic constipation is a real problem in many mitochondrial problems. And what we found in measuring the citric acid cycle in intermediates is that the level of citrate often is low. Now, unfortunately, I have not been able to measure that in KAT6A, but to go through a sequence, citrate is low. So citrate is made by mitochondria. Mitochondria are working well, they make a lot of citrate. The same citrate as the citrus juice. That citrate is the only source of acetyl-CoA in certain types of cells. And that acetyl-CoA and the primary neurotransmitter of the gut is acetylcholine. And therefore, if acetyl-CoA, and that's made from acetyl-CoA plus choline, if acetyl-CoA is low, then the gut doesn't work as well. And what we found in treating a number of children with mitochondrial problems is that simply giving citrate will increase the production. You can presume it's increasing the production of acetylcholine for the gut, and the gut starts working. The first time I used this, the child is on a drug that's not available anymore for Tulsi, because she had severe constipation. She went once every several days. I put her on what I guessed would be the right amount of citrate. And I had a stat call from the floor saying that she's having diarrhea. So we just backed off on the dose, and ever since then she's been fine. And I've done this in a number of patients. So-called, you may have read about pseudo-obstruction. And a typical mitochondrial disease, the primary cause of pseudo-obstruction is the deficiency of citrate. And we were able to show this by measuring citrate in patients in their blood. And when it's low, they typically have constipation, reduced citrate, and the gut starts moving. So I want to say it's not going to be the cause of all constipation, but it's happened enough children, as I say, have been put on citrate to believe that this is an option and needs to be explored. They're very specific. I've worked out now exactly what dosage one should start on and how much to increase to see when it's going to work. So, it's not published yet, but it can be very effective, and it's much better than giving all these medications. It's quite natural. One interesting story, there's a boy who had autism, Autosomal Dominant, and very severe constipation. And before I started treating him, his father told me that they had to lock the refrigerator because he would go into the refrigerator, find a bottle of real lemon juice, and drink it down. And that's very high citrate. It's as high a citrate as a medication form. So he was treating himself. He really felt better when he drank that. And so just to show you that it's a very important aspect of certain mitochondrial. So that's the one.
It's fine. I just was trying to understand, are you saying that sometimes there's an actual physical issue with the intestines and sometimes it has to do with low citrate levels? And you're seeing both in KAT6A?
There's evidence of there are structural problems that could be, there could be in some other genetic conditions, there's a absence of nerves, there's a gap in the gut that has no nerves, or Microcephaly is often caused because there's a restriction or hematoma or lump extra tissue on the inside of the gut that serves as the starting point of this process. Essentially what is happening in the gut is taking over on itself. And it's more patients now are patients who have that. But that's a pretty high incidence. If you think there is something that hasn't had insusception, and it's just not a common thing. And usually, it could be due to constipation by itself, but most children have severe constipation do not get insusception. That's why, because there are other structural defects in KAT6A, one has to wonder about that. Now, most of the patients who have insusception, they did not find a structural problem. Or one child had to have two portions of colon cut out because of it. So it's something to be aware of. Chronic stomach pain, especially if you have bloody stool, that's a sign of insusception. It's high, it's not 4 out of 25 liters. That's pretty high on those things go. It's not the same way. Certainly the children don't have it, but it's one of the things that needs to be. I couldn't find it on the KAT6A list. That's one of the things that needs to be on the list, especially for the GI doctors who are seeing KAT6A.
So I think a lot of the families have constipation issues in general. So just based on your indication there that citrate or citric acid could potentially help, is there something that we can do over the counter or just dietary change that you recommend before we know anything more, just to see if it helps?
I would not recommend lemon juice. It works out, I calculated it, the concentration of citrate in the lemon juice is exactly the same concentration on the medical form, medicine form. It's now called, it used to be called polycitrate, it's now called citrates, it's the most concentrated form. And I would not, it has to be given by a prescription. And what I need to do, I haven't done it yet, is I need to write out the protocol, write out an explanation, why it occurs, how much to give it. I usually start out with a certain dose, 200 milligrams per kilo per day, and then increase it in steps. It usually works by 3, which is not a huge amount.
It's very safe in those amounts, and it certainly is worth a trial if nothing else is working. So I just need to write that out.
Okay, and then once you write that out, similar with the vitamin cocktail formulation that you had written out previously, I presume at that point we could have our physicians start to describe it.
I have I've updated, what you have read, I think, in the past is a summary on mitochondrial autism, which the treatment for mitochondrial autism is very much the same as what I would expect for KAT6A if it needs analysis. But the principles of treatment, some of the things I've discussed here are detailed in that. I've just revised it. I have to edit it a few more times, and I'll make that available to the group. It's much more comprehensive. It has a lot of references now, which is what doctors like to see. So it's a much more medical document. It's not made for the patient. It's still a how-to guide. It's a how-to guide written for physicians, and they'll hopefully make use of that. I am going to put in there, I haven't done it yet, but I'm going to put in there the consultation issue. So that might be enough.
Okay.
But I'll also write it out as a separate protocol that one can give to the physician.
In the meantime, no lemon juice, though.
In what?
In the meantime, no lemon juice. What if they'll drink it, right? Like so.
Well, I say, it's really interesting in these metabolic conditions. The children know what they need.
Yeah.
The bar syndrome, where the deficiency is RG, if you take down a standard diet, what the children eat every day, it's very high in RG. And one of the things, and it's also, they have low amounts low RG of chicken, nuts, all the things that are high in RG, that's what they choose. So if the child is raiding the refrigerator, you know what to do.
Dr. Kelley, on the same topic, can you please talk about the metabolic acidosis because it's related to the abdominal pain?
Yeah, I generally, so metabolic acidosis, if someone does not make enough bicarbonate, that's called metabolic acidosis. There are other kinds, but that's the basic point. The alkali, or the bicarbonate, is in effect made from citrate. That's the source of many things. And many children who have this acidosis, they take bicarbonate, they take citrate to make the bicarbonate. Now Peter has low bicarbonate. He has a true metabolic acidosis. I have not seen that. I can't say that it doesn't exist, but part of the studies that many have done were electrolytes, I did not see metabolic acidosis in that. And we do see it sometimes in classical complex lung deficiency, and sometimes we don't. If the citrate deficiency is severe, then yes, a child will develop a metabolic acidosis. When the citrate deficiency is more borderline, I generally don't see the acidosis. But still, the citrate, even though there's no metabolic acidosis, the citrate still works for constipation. So like the amino acids, it's a relative deficiency. And it's because it's a benign compound, it's always worth trying that if nothing else has worked.